Thank you, Dr. Ross. It's a really a great pleasure to be here. This is a very nice place to have a meeting, and congratulations on the 10th anniversary. So I'm going to talk a little bit about popliteal artery management, kind of give you an update of where we stand with the management of popliteal artery aneurysms. I don't have any disclosures. But before I start, I just want to go a little nostalgia here. Dr. Ross and I trained at Vanderbilt together, and there he is as a chief resident in 1990. And one of the great professional privileges of my career is have been being interacted with Dr. Ross, both personally and professionally, over the last 30 years, and really appreciate his invitation to this meeting. And thank you, Chuck, and congratulations. Just a picture of Dr. Ross and a couple of comments from the internet on him as a surgeon. As you can see, very laudatory, demonstrating the quality of surgeon that he is and the impact that he has on patients' lives and their families. So I'll focus quite a bit on the guidelines that just came out in 2021 for popliteal artery aneurysms. It provides a nice guide to how to treat this entity currently. And as you well know, it's the most common peripheral aneurysm. It's a disease of the elderly. Very uncommon in females. I'll touch a little bit on that at the end of the talk. And they're frequently bilateral and associated with aortic and contralateral popliteal aneurysms. Looking at the natural history, complications, once recognized, complications develop at an average of about a year and a half. And the complications, if they do occur, lead to a high rate of amputations, 25%. So aggressive treatment to minimize that risk is warranted. About 50% of patients, however, are free of complication at 5 years, and this does play into treating these aneurysms in the more elderly patient population with high comorbidities. Now, the natural history is embolism, thrombosis, distal obliteration of runoff vessels with limb ischemia. Rupture is rare, but the ultimate end game is amputation if not treated and just left to the natural history. And the risk factors for accelerated growth and issues of popliteal aneurysms include aneurysm thrombus, and I think that's an important distinction. Really, regardless of the size of the aneurysm, if thrombus is present, you should be concerned and probably be a little bit more aggressive about treating it. And of course, the mean starting diameter is also related to the rate of growth of these aneurysms. Now, the indications for repair, there is the acute thrombotic event, which patients present with acute limb ischemia. That is handled very differently than the elective approach. The recommendation for repair is any aneurysm greater than 2 centimeters, and as I mentioned, any mural thrombus, evidence of distal embolization, or chronic thrombosis associated with chronic limb ischemia. And this is a grade 1 strong recommendation from the society guidelines. Now, in the acutely thrombotic situation, the Rutherford classification is important. For those that are 1 and 2A, thrombolytics, pharmacomechanical thrombectomy is the first line and appropriate. And in this paper that came out in 2012, looked at a group of patients in which there was first an attempt at thrombolytic therapy and then revascularization versus just immediate surgical therapy. And the amputation in the DSG, which is the delayed surgical intervention, was much lower than those that immediately went to the operating room for revascularization. And this was despite the fact that there was less open infrapopliteal arterial tree in that group, really suggesting and documenting that thrombolytic and pharmacomechanical approaches are the way to go in these patients. Now, for the Rutherford 2B, you may need to do a combination of pharmacomechanical and even open thrombectomy, but you've got to get some kind of runoff established before successful revascularization is going to occur. And And this is the recommendation, also a grade 1, very strong with good level of evidence with regards to the care. Now, elective repair, we have a number of options, and this has been a focus of a lot of controversy and research over the last decade. There's the medial approach, which is the most traditional and oldest way of treating these aneurysms. There's the posterior open approach, and then there's endovascular stent graft. So we'll talk about the medial approach open. This is basically a medial bypass with exclusion of the aneurysm by ligation, hopefully taking geniculates as well that come off the aneurysm, which can cause a problem in the future. With an autogenous bypass graft, if you have autogenous tissue, and preferably you do, because most of these bypasses are to the popliteal artery below the knee. And this is a 33-year experience from Italy, a very large number of patients, open interventions, pretty reasonable 5-year, 10-year, and 13-year primary and secondary patency rates, demonstrating the relative durability of an open approach to popliteal artery aneurysms, as you can see here. But one of the problems with this approach is basically the type 2 endoleak from the geniculate vessels that come off of these aneurysms, and then later expansion, in this particular case, rupture. But neurocompressive symptoms are actually more common in this presentation. It's rare, but it does happen, and it's a big problem. So because of that, posterior approach has been developed, which is the one that I prefer. It's a very direct approach, S-shaped incision, eliminates really the late sac endotension issue, and really the only limitation is how far these aneurysms extend proximally up to the adductor hiatus. If they're beyond the abductor hiatus and involve the superficial femoral artery, this approach is just not going to work. And this is a paper from Wes Moore looking at actually using prosthetic and as opposed to saphenous vein graft. And as you can see, even with a prosthetic graft, fairly decent primary and primary assisted patency rates over a 2-year period with 100% limb salvage. This is another approach as far as conduit is concerned that I thought I'd just show. I've never done this, but was recently published by a French group using superficial femoral artery transposition. So they basically harvest the proximal superficial femoral artery that's normal. They transpose it and use that to actually repair the popliteal artery aneurysm, and then put an interposition of PTFE to replace the transposed superficial femoral artery. And this is some pictorial of that particular approach. They had excellent results. It's just something to know that you could use in a pinch when you don't have autogenous conduit, a greater saphenous vein available. Now, looking at posterior and medial approaches for popliteal artery aneurysm repair, some meta-analysis, about 1,500 patients, posterior and medial approaches with good follow-up. And they demonstrated improved exclusion and lower reoperation rates in the posterior approach. This is from that paper with an odds ratio of 1.1 and 1.61, significant p-value. And I think really at the state of the art at this point in time is a posterior approach, assuming that from an anatomic perspective it can be done. Now, endovascular repair has increasingly been used, and there's a lot of reports out there. There is no prospective randomized trial. There never will be a prospective randomized trial, but there's a number of meta-analyses. I'll show you 2 of them, kind of comparing open and endovascular repair. It's obviously very attractive, minimally invasive, less painful, with a much quicker recovery. This is a patient of mine who I actually operated on the right leg, but then had a large patent aneurysm on the left leg. This individual was about 300 pounds. I really didn't want to go through operating on him again, and so I decided that we would place a stent graft, and I did that, and it's very nice. He had 2-vessel runoff, not too much tortuosity, fairly reasonable length, and it looked beautiful when we were done. Of course, one of the concerns is that this happens, and this happened about a year later. One of my concerns with using stent grafts for popliteal aneurysms was I felt that once that stent graft went down, there would be, basically it would turn into an acute limb ischemia type picture with increased risk for limb loss. And I will show you that the data suggests that that is not the case. This individual actually presented after this thrombotic event with basically some leg pain and claudication per se, not limb-threatening ischemia. So the clinical outcome of using heparin-bonded stent grafts, this is a paper from Europe, 72 popliteal artery aneurysms in 70 patients, 100% technical success. The 3-year patency is quite good, and if you remember that the article from Dorigo, really quite complementary and quite comparable to the open approach. And the key thing, at least that I found in this paper, there's no major amputations that occurred at follow-up, which is remarkable and something I did not expect in using this particular approach. One of the important aspects that's been found is that using, if you're going to use a stent graft, runoff is very important. And this is a paper from the Mayo Clinic looking at a comparative between their open and endo approaches to popliteal aneurysms. And they found that vessel runoff is really the most important determinant of stent graft patency. If you have 2 or more runoff vessels, then stent graft patency is quite good. But only 1 runoff vessel will really decrease the patency of this particular approach. This is a meta-analysis comparing both open and endo. One of them, one of the many in the literature, this is 2015 from the European Journal of Vascular Surgery, endovascular surgery. Length of stay was obviously less with the endo, however, 30-day graft occlusion as well as reintervention rates favored open repair. However, if you looked at limb loss and primary patency, there was absolutely no difference between endovascular and open repair with either approach. Now, you have to always keep in mind that the endovascular group is a fairly very distinct group of patients with probably better anatomic features than patients that have undergone open repair, such as runoff. And this is from Macaroon's group in Pittsburgh, looking at open and endovascular repair, looking at 14 studies. Higher wound complication, obviously, in the open repair, but lower thrombotic complications in the open repair and better primary patency. However, secondary patency was completely the same, and again, limb loss was no different between the two. Now, this has led this literature, and there's many other meta-analyses. They all kind of show the same thing, but this has led to the recommendation, at least from the SVS's perspective, that in a good risk patient with a decent life expectancy, that the preferred approach is an open repair with a good saphenous vein graft. Now, if you don't have a good saphenous vein, some of the other issues, then that obviously changes things. Also, that patients with limited life expectancy, i.e. less than 2 years, probably don't need to be managing or treating them at all for this popliteal artery aneurysm, and that is in light of that natural history data that I showed earlier. Now, I just want to make a comment about women, because there are very, very few women in any of these series, less than 5%. So this is a VQI study from Dr. Mollis at UCSD. It's in press currently, and you can see the number of females in VQI with popliteal aneurysms treated was less than 5%. They found a couple of important things. Number one is that women present more symptomatic than males do, that they have a more extreme presentation, and consequently this led to a higher risk of major amputation, as well as a higher risk of amputation or death. And if you looked at the Kaplan-Meier, they actually had a decreased amputation-free survival. So this brings up the point that with females more symptomatic at the time of presentation, are we not being aggressive enough? Should the size criteria that we used, which had been established basically for males, should that actually be the criteria that we use to treat females? Kind of similar thing with abdominal aortic aneurysms and the differential between the thresholds for repair in females versus males. So this is something that needs to be sorted out in the future, but I think it's something it's important to keep in mind when you do see a patient, a female patient with a popliteal artery aneurysm. Probably should be a little bit more aggressive in treating those patients. So as far as the update, this is currently, I think, kind of the state of the art for popliteal artery aneurysm repair. Pharmacomechanical thrombectomy is the first line for any acutely thrombosed popliteal artery aneurysm. Open repair by a posterior approach, I think, does have an edge. Endovascular, the ideal patient, 2 to 3 vessel runoff, focal popliteal aneurysm with good landing zones above and below. Open versus endo, the SVS guidelines favor open, assuming you've got a good saphenous vein, but the grade is weak because the quality of evidence is low. And probably always remain low. This is kind of the limitations of being able to study the comparisons between these two. And finally, should the approach to popliteal artery aneurysm in the female patient be different? Should we be more aggressive? I think, based on at least that one study, that we should be. Really appreciate your attention, and be happy to participate in the panel at the end.